25-hydroxyvitamin D is one that we always need to measure. In the future, we're going to have more molecular diagnostics, more genetic testing. We move towards from classic clinical chemistry to mass spectrometry in the detection of molecules, which might be more accurate. My name is Konstantinos Makris. I'm a clinical biochemist by study and training. I am director in the clinical biochemistry department of CAT Hospital, which is one of the biggest trauma hospitals in Greece. Pregnant women, especially during the third trimester, vitamin D binding protein is very high. Common methods like immunoassays cannot dissolve the association between vitamin D and the D binding protein. Sometimes underestimate the vitamin D levels in this population. This is not the case with LC-MS/MF methods because they use stronger chemicals and they can dissolve the association between D binding protein and 25 and vitamin D. On the other hand, 125, the active hormone, testing this is not very well documented in the general population or other specific populations like chronic kidney disease persons, because 125 will always be within the limits of the reference limits in the population, because organism will always have this hormone produced by 25. On the other hand, 25-hydroxyvitamin D is more important even for special population like chronic kidney disease people to measure it, because even if the kidney cannot produce the hormone, vitamin D can absorbed by the target organs, and 125 can be produced there locally. Measure the 24-25 and divide these two numbers and get the metabolic ratio. This metabolic ratio, it is important also to know because it gives us an estimation of the efficiency of vitamin D in the organism. Vitamin D, especially the 25, the measurement of 25-hydroxyvitamin D is very well standardized. However, we can say that immunoassays might show some interferences from other metabolites of vitamin D, especially from the epimer of vitamin D. So we are only depending on immunoassays, which results in between methods and between labs and are not very well standardized. I think that future solutions in the detection of various metabolites of vitamin D could be multi-analyte measurements with LC-MS/MS maybe, which can measure 24, 25 to 25 vitamin D and also the epimer, and also it can discriminate between the various metabolites, and even if it's vitamin D2 or vitamin D3, and also can give the laboratory the information of all these molecules, and then also can calculate the metabolic ratio. Low levels of vitamin D are related with skeletal effects and risk of fracture. But for the rest conditions that you have mentioned, we don't have solid data and we have conflicting data, because not because vitamin D has no effect, but because levels of vitamin D have not been solidly related with these conditions and the improvement. We need better studies to be conducted, and then meta-analysis of the studies, and also we need to have homogeneous populations concerning the levels of vitamin D at baseline in order to examine the effect of supplementation and to have the results in these areas. I think that in the future we're going to have more molecular diagnostics, more genetic testing, and we move towards from classic clinical chemistry to mass spectrometry in the detection of molecules, which might be more accurate. I think that the most impressive advancement that Mindray has done the latest year is the full automated systems that incorporate pre-analytical, analytical systems, including clinical chemistry analyzers and immunoassay analyzers that gives the laboratory the ability to handle all the daily routine very efficiently and have very well control of the daily routine.